Hi, everyone. Thank you so much for taking the time to join us today. My name is Brooke Jacobson, and I run partnerships and marketing at R0. I'll be the moderator today. We know you are some of the busiest people in the world, especially right now. So in the interest of time, I'd love to dive right in and introduce R0 and our hosts for today's webinar. R0 is the first biosafety company to take hospital-grade disinfection technologies and methodologies and map them to dynamic organizations with a focus on schools. We are modernizing disinfection and really creating a new standard by taking a science-backed and technology-forward approach. And that approach has been heavily influenced by Dr. Richard Wade, our chief scientist. Dr. Wade has spent the last 43 years in health, safety, and environmental risk management roles for multiple city and state governmental bodies, including his time as deputy chief for Cal OSHA. He's a frequent guest lecturer for environmental risk management at Oxford University, an adjunct associate professor at the University of California, San Francisco, among others. As a longtime member of the National Academy of Science, Dr. Wade was brought in by the Department of Defense during the Ebola outbreak to provide guidance on how to navigate the disease. In April, Dr. Wade was brought in to develop a tactical response plan for decontamination of the Diamond Princess cruise ship. And most recently, in his work with R0, he has been focused on advising and helping schools and other organizations in developing protocols and risk reduction procedures to combat the COVID-19 pandemic and beyond. Eli Harris, one of R0's co-founders, is a Forbes 30 Under 30 entrepreneur and 2 times Fulbright scholar. He previously lived in China for 8 years, where he co-founded and served as CEO of a manufacturing business called EcoFlow. He exited that business last year, came back to the US, and was doing some volunteer teaching when the coronavirus pandemic changed the world indefinitely. He got together with our 2 other co-founders and Dr. Wade, and looking at the social and economic devastation that occurred, they really felt a duty to help the hardest hit organizations restore both safety and trust in their environments. So that brings us to today's webinar. Our goal here is really to meet you where you are on your journey to implementing a holistic, effective, and sustainable infection prevention program to aggressively mitigate risk within your facility while minimizing incremental costs and the disruption of day-to-day operations. We have a range of schools represented here, some that are still fully virtual, schools employing a hybrid model, and schools fully in person. Districts have also been affected differently. Some of you may have had outbreaks and have had to shut down for a period of time. Some of you have had very few, if any, cases. To set the stage, today we'll be speaking to the middle of the road, where infections aren't out of control, but the virus is still persistent and top of mind. We also want to speak to the world beyond COVID, which of course seems hard to imagine right now. But incorporating effective disinfection practices will continue to pay dividends long after the current pandemic. The same measures you implement to reduce the spread of COVID will be effective at reducing the spread of other common infectious diseases like the common cold, seasonal flu, norovirus, to name a few, and will help reduce sick days and increase student attendance in the years to come. So as far as the agenda, I'm about to hand things over to Dr. Wade, who will be speaking on the latest coronavirus outlook. We'll then dig into what we can learn from hospitals' layered approach to disinfection and end with a couple of examples of those best practices in action in schools. So Dr. Wade, I'll hand it over to you for fun and lighthearted first topic.
Thank you very much, Brooke. I appreciate the opportunity to be here today. Unfortunately, some of the things we're going to talk about are COVID. It doesn't look good for the next few months. CDC, WHO, and all health organizations are warning us that we're in for a lot more increase in cases in the next few months. Currently, the United States is averaging 100,000 new infections a day. This is the most since early August. New cases were up 46% over the last week. That's the 6 straight weeks in a row we're seeing increases. It's after the surge that's occurring in the fall after our summer surge. Hospitalizations are up also. Today, 50,000 people are in the hospital suffering from COVID. It's the most since August of this year. And many states have occupied intensive care units at capacity. The death today was 1,079 deaths, where we've been averaging the last 2 weeks about 900 deaths a day. When you look at your communities, and I'm going to be focusing today on looking at the community and how that affects the risk of children of which you are responsible. Another key metric is the percent positive, it's called the positivity rate of all the tests that are being conducted. Right now in the US, over 1 million COVID tests are being done today. The positivity rate, that's what percentage of people are positive, range between 2 and 50%, depending on where you are in which community. Some areas of the country, we are at 2 to 5%, some areas at 50%. The goal is to keep the community positivity rate less than 5%. And that affects the community incidence of the disease, but it also affects how much disease is in the community affecting your children. We can expect to see this number of cases go up, and that's why most WHO, CDC, and all the public health agencies are expecting significant increases in the fall and going into the winter until a vaccine is available for distribution. And until that time, what we have to control the virus is disinfection of surfaces, social separation, and wearing of masks. But as we get in more indoor congregation in the winter months, holidays, social gatherings, merging with the flu season, it doesn't look good for the future. So there's no question there's a lot of disease out there in the community. What's happening in children? Many cases, children don't exhibit any symptoms at all. It's either mild or very small symptoms. The severe cases, it's less than 7% of all COVID cases are under 19 years old. And the hospitalization rate is far less than 1%, and the severe cases are less than 0.001%. And they don't have serious health significant implications for themselves. Why is that true? Because their immune system is more adaptive because they're exposed in an early age to more viruses and bacteria, and they're not getting the more latent immunological response to the disease. So they're not feeling the direct ill effects. There's a tremendous emotional and mental health issue of keeping kids out of schools. And that's why the Academy of Pediatrics, the World Health Organization, the Center for Disease Control, all say whenever possible, kids should be kept in school. What does whenever possible mean? Generally, public health people look at seeing the community incidence of COVID is no greater than 5%, which it is in many areas of the country. Where you've got incidence of 10%, 50%, then you've got more disease in the community and you need to take extra precautions or maybe not have the children in school. What do we know about the transmissibility of this virus? We know the virus spreads through coughs, colds, sneezes. There's two types of viral distribution. One is the large droplets and the other are aerosols. The large droplets are the mucus from nose and mouth discharges when you cough or sneeze, or even when you're talking. The aerosols are small viral particles, independent, which are transmitted through the air, independent of the mucus droplets. The significance of this is both of those will eventually drop onto surfaces, that they'll become airborne. The large droplets generally don't go more than 6 feet without any respiratory protection, no more than a couple feet with a mask. Aerosols, however, can go out to 6 to 10 feet or greater, and depending on air circulation in the room in which they're discharged. Studies have shown time and time again that the exposure to children in schools, people in the community, is both direct and indirect, and close contact with an infectious person who is secreting respiratory droplets and sneezing, coughing, talks, or sings, or singing in choirs has been known to produce outbreaks. And then all these droplets have to, by gravity, settle someplace. and they land on contaminated surfaces. And then we show that in this slide, you can see cardboard, these viruses can last 24 hours, plastic and steel 3 days, wood 4 days, and glass up to 5 days. So the virus becomes non-viable after those periods of time. So in order to effectively manage the risk, we have to look at how do we kill the virus, or not kill, but inactivate the virus in the air and on surfaces. And that's what brings us to UV light. The UV light is able to inactivate these viruses when they're suspended in air and also as they're deposited on surfaces. So I think with that, we've talked about children, risk. Eli, let's get a little more specific in how people can help reduce risk.
Thank you, Brooke. Thank you, Dr. Wade. This is Eli Harris speaking. I'm one of the partners of the business. First, I want to thank everyone who's listening today. I really appreciate the seriousness with which you're taking this topic. As Brooke mentioned earlier, my background, the first decade of my career was as an entrepreneur in hardware manufacturing. And I had good fortune and left that business last year. And I was actually doing some teaching at a high school in California. And I was teaching when the pandemic changed the world as we know it. So at that time in March, I got in touch with two other entrepreneurs and technologists who are both extremely successful. And we pulled Dr. Wade in. And what we did is we actually, with the intent of building and optimizing and designing a program to help schools reopen, Dr. Wade led us on a study of hospitals. And the reason we did that is because we figure ever since their advent, hospitals are a place where we actually encourage the ill to gather, and we need to learn how to control the transmission of pathogens among those vulnerable people. So at this time, Dr. Wade gave us a little, he led us on a research study. And we learned that hospitals fundamentally do three things. And in this next part of the discussion, I want to break down each of those three components and extrapolate on how those can be expanded into schools. The first layer of infection prevention that we're seeing in the healthcare settings is hand hygiene. We see doctors always scrubbing in and scrubbing out or washing their hands when they enter a room. And we don't have to convince you that this is equally important in schools, as there's plenty of studies that show that hands really do have a mind of their own and they're a great conduit for germs. Again, not just COVID, but also the common cold, seasonal flu, norovirus, or the stomach bug. Hand hygiene is proven to be effective in both increasing attendance and reducing sick days. So it's really important that schools do their best to practice good hand hygiene. You can do that by promoting hand washing with visual cues around the campus. You can bake time into the daily routines for the students and staff, whether that's in between classes, at lunch times, during breaks. And some of the younger students, you might even want to go on some guided trips. Of course, you also want to place hand sanitizer throughout the facility in locations especially that are high throughput, high touch, in and around entrances, bathrooms, drinking fountains. And it's also really important that you use a solution that has a minimum of 60% alcohol-based concentration. The second pillar of the hospital protocols is manual disinfection, and that's the hand wiping of surfaces. And again, this is very important and it is very effective, but it is very labor intensive. And unfortunately, even recent studies show that in hospitals where you have very highly trained workers, oftentimes up to 50% or even more than 50% of surfaces are actually missed during manual disinfection. So understanding this, I think it's really important that we do employ manual disinfection, but we really focus on where we employ it and that we address the high touch, high risk areas, as opposed to imposing a blanket mandate that your staff wipes the entire space, because then you're creating an environment that's going to lend to human error and spaces being missed. It's also important to know the difference between cleaning and disinfection. Cleaning is the physical removal of particles and matter and dirt and germs from surfaces. And it's important that we still clean, and we go and we clean these school environments, and then we follow that with disinfection. And that will allow the chemical solution to actually interface with the pathogens that are left over, as opposed to being blocked by any dirt or matter on the surfaces. It's also important to use the right chemicals. So make sure that the chemicals that you use are on the EPA's list N, which is verified for use against SARS and the human coronavirus. It's also important that the staff is trained. For example, different chemicals at different contact times. You should leave the chemical exposed to the surface for a certain amount of time before you wipe it. And secondly, you want to make sure that your staff is trained to use the proper protective measures to keep themselves safe. The last part is what we're really interested in, and this is where Dr. Wade really gave us a good education. So the gold standard in all hospitals today is the use of UVC light. And these are large UVC light towers. They're essentially lights on wheels with a timer. And it's a certain bandwidth wavelength of light that has the ability to penetrate any microorganism, any virus, bacteria, mold, fungi, and it ruptures the DNA or RNA and renders that pathogen incapable of reproducing. And what's very fascinating is UVC is actually extremely old technology. In 1903, the Nobel Prize for Medicine was awarded for the discovery of the germicidal properties of UVC. In the 1910s, we started using UVC light in wastewater treatment. The 1920s, we rolled it into HVAC systems for disinfecting air. The 1940s, we started seeing it in hospitals, and then it took off in 2008. And what actually happened, this is very fascinating, but it was Obamacare. So Obamacare did two things fundamentally. One, they raised taxes, and two, is they looked for inefficiencies in spend in healthcare. And what we uncovered was that Medicare and Medicaid were actually reimbursing hospitals for most hospital-acquired infections. So if you went to a hospital for a small surgery, and then you left with staph or C. diff or something else, that was a $30,000 financial liability for the hospital, but it was reimbursed. And when they were looking for those inefficiencies in spend, the government said, you know what, hospital, this happened on your watch, we're not going to cover it anymore. So in 2008, there was finally an increased financial incentive for hospitals to reduce the incidences of infections in their venues. And because we started using UVC light in hospitals in the 1940s, there was 78 years of clinical data and trials that showed that the hospitals that did use these UVC light towers did in fact have lower incidences of hospital-acquired infections. So in 2008, it took off. And now the use of UVC light is the gold standard in operating rooms and patient rooms when one patient leaves before the next one enters to make sure that what one patient has isn't carried to the next. So as biosafety is now becoming more important in commercial venues, we're seeing this technology actually move out of hospitals into commercial spaces. So we're now using these systems in schools, and they become part of the janitorial staff's toolkit so that as they go around cleaning these rooms, at the end of the manual cleaning of a classroom, a bathroom, a teacher staff room, a cafeteria, you wheel this light in, you press a button, and it runs a cycle, and it will emit light at this certain wavelength that can kill any microorganism based on a duration of time. And those best solutions out there, like the solution that we've developed, they actually have an audit trail and software reporting so that you can actually see what time each device was ran and which room it was ran in. So you can actually see, okay, classroom 11 was disinfected at 11 o'clock last night, but somehow classroom 17 was missed. And from a liability and a risk mitigation perspective, the ability to actually see what the janitorial crew is doing is extremely powerful. Because the truth is, when you send the crew in to clean, you don't actually know what happened. You don't know what was wiped, what was sprayed, what time they were in each room. And the ability to have this execution compliance and this audit trail and reporting around the use of these lighting systems is very powerful, both from risk mitigation, but also you have the ability to show that reporting to teachers, to parents, to students, and regain trust and make people feel comfortable going back to work, going back to school, and going back to these shared spaces. There also is fogging and electrostatic spraying. This is a different type of technology. It is also effective. It is optimized for different places. It is a chemical, so you don't want to use it in areas where people might put things in their mouths or ingest items, but it is very good for large open format areas like auditoriums or playgrounds. And what it does is it's a machine that applies a positive charge to a liquid disinfectant, which then results in it spraying, and it's attracted to negatively charged surfaces. And then when it attaches to those surfaces, that chemical will inoculate the pathogen and kill the pathogen. So it is very effective, but there are chemicals involved, and it does require a full-time laborer to suit up and practice appropriate safety measures. I think what we'd like to do next is actually look at some schools today. Oh, sorry, Dr. Wade, I stole your thunder.
Yeah. No, I was listening to you. Very good information. There are a couple of things I think from a medical standpoint let's take away. One, any prescription you have for dealing with a school, we know that you guys have been battling this in a very charged environment for the last 8 months. That those emotions run very high when it comes to protecting our children. So there's a couple things I'd like to have you take away today. There's no silver bullet. There's options out there, as Eli has been discussing, but you need to, like a physician writing a prescription for a patient. Every patient is different. Signs and symptoms are different. Every school is different. Every community risk is different. So you need to look at the layered approach and what's best for your school. But the commonality is the techniques that Eli mentioned, hand washing, separation of children as much as possible, wearing masks, cover the nose and mouth. The University of Washington just recently did a study showing that if 95% of people wore masks, then we could save 100,000 lives in the next 4 months. 100,000 lives. That's if 95% of people wore masks. Right now, the nation average is 50%. So we got some work to do there. Mm-hmm. So you're doing a lot. There's some tools out there. I think R0 and the UV is an important tool, but it has to be put into an array of tools. If there's one thing I could leave you with a take-home lesson, if you will, is look at your ventilation systems. Ventilation in the classroom is so important. So I think Eli will now bring home some of the practical and things that people have done successfully.
Yeah, so as Dr. Wade says, there really is no such thing as risk prevention. It's all about risk reduction and looking at the holistic approach, that layered approach to bring that risk down as much as possible to keep folks safe. So what we want to do now is I just wanted to call out 2 schools, districts in general, that have implemented some really good approaches addressing this pandemic and this new attention to biosecurity at the holistic level. One of those is North Monterey County School District. And this gentleman, Diaz, who's the director of facilities, and he's phenomenal. And he's agreed to be a resource. So if you would like to touch base with him after, please feel free to contact me. But Rick has taken a really impressive, comprehensive approach that's very thoughtful. He added portable hand washing stations to the exteriors and hand sanitizer at all entrances to the campus. All shared equipment, printers, copiers, etc., any gym equipment, it's all wiped down before and after any use with sprays and microfiber towels. The playground equipment is disinfected with a leave-on chemical applied via backpack sprayers, and it even leaves 15 minutes of dwell time before he wipes them down so that the chemical can actually properly inactivate the surfaces. The UVC lights are used in the evenings to disinfect the entire campus, and the device trails the custodial staff during their manual cleaning. So if they go and clean one room, when they're done, they'll clean a room, they'll vacuum it, and they'll run the light in that room. And while it's running, they'll work in the next room. And then throughout the day, in some of the high traffic areas, like the nurse's office, teachers' lounges, and all bathrooms, they'll actually run the system throughout the day, as those environments are much higher throughput and much higher risk. Their vans and buses are disinfected with electrostatic spraying. Face coverings are required at all times except for eating. And they've reduced the classroom capacity, and they're doing a hybrid A-B schedule. Also very important, as Dr. Wade mentioned, is they've invested in oscillating fans, which help with the air circulation in some of the older buildings. And temperature screenings via thermal scanners are conducted at all entrances every day for all students and staff. And even if they leave the campus and return, they have to have an additional screening. and an additional sign-in sheet for contact tracing. And all of their sites are completely outfitted with signage at every entrance, general pathways, at hand washing stations, both for social distancing and also as cues for reminders about good behavior. And actually the county of Monterey actually contacted Rick proactively to commend him for his use of signage on the campus. So thank you, Rick, for all that you're doing. And again, if you'd like to talk to Rick, please feel free to contact me, and I'll try my best to put you in touch. The second school I'd like to highlight is Roland Hall School. They are a private school in Salt Lake City, Utah, and Gita Varner is our champion there, and she's been the project manager for their reopening. And I believe Gita would also be receptive to any conversations. So again, feel free to contact me if you'd like a reference. They've implemented hand sanitizing stations installed in every single classroom and at every single entrance of both of their campuses. They've added portable outdoor camping sinks all around the campus. The teachers are leading younger students in washing hands, and older students have self-monitored time padded between classes, specifically for hand washing. The in-house cleaning staff is wiping down all high-touch areas, door handles, light switches, bathrooms throughout the day. In middle school and high school, students have been actually given their own equipment and tasked with their own responsibility to wipe down their desks before and after each use. And they've also hired a cleaning crew on top of their standard janitorial staff that's coming each night to wipe down all high-touch areas and deploy the UVC devices. The UVC devices, like North Monterey County, are run each night in each of the classrooms, as well as in the high-traffic areas throughout the day, including the lunchrooms, the nurse's office, the staff areas, and the bathrooms. The buses receive electrostatic spray downs once a week. The drivers wipe down the seats, and they've also mounted hand sanitizing stations on every single bus. Face coverings are required at all times. Class sizes have been reduced. Common spaces have been repurposed as classrooms so that we could have fewer kids in each class and still have more classrooms. And then teachers have actually been fixed in their classrooms and paired up with cohorts of students, so the students are not changing between classes and changing teachers as frequently. And they've also embraced signage and floor tape as part of their protocol to ensure proper social distancing and place cues around the campus. So congratulations, and thank you, Gita, for all you're doing to keep the community safe. And lastly, I mean, we built this company specifically to help schools reopen. We all come from a technology background, and Dr. Wade has been instrumental in helping us craft our programming. And what we're doing is we're really studying what hospitals do as the gold standard and figuring out how we can best optimize and map those technologies into school environments. And really, this goes beyond COVID. There's going to be pandemics for the rest of mankind. And then also, I mean, there's also the common cold and norovirus and E. coli. And right now, 40 million people a year get the seasonal flu. And for some reason, we've just accepted that as normal. And the measures that we're taking today to prevent the spread of COVID are also going to be very effective at reducing incidences of norovirus, the stomach bug, the common cold, and can result in increased attendance, a decrease in sick days, lower substitute teacher costs, and just healthier children and communities at large. And I think it's also really important as we adopt new measures that we're very vocal with the community about what it is that we're doing differently. Like I said in the beginning, part of this is safety and part of it is trust. And we need to regain trust in the community. And part of doing that is articulating the changes that you're making, whether that's through the reporting of showing the disinfection trail of the UVC light and the other measures that you're taking, or whether that's through badging and signage. It's really important that we're vocal about all the changes that we're making to keep our students, our staff, and the community safe. So thank you all for your time today. We're very grateful. Broker Dr. Wade, I don't know if you have a closing remark, but I'm very grateful to hopefully have had your attention for a short moment in time, and I'm grateful for the work you guys are doing to keep our community safe.
Yeah, well, thank you all who are out there every day on the front line protecting these children.